I want you to picture the human heart, but not just as a mechanical pump. I want you to picture it as this active, heavily fortified, microscopic battleground.
Right.
Because we usually think of the heart as this pristine, sealed-off engine, right? I mean, it beats 100,000 times a day,
Yeah, exactly. Maintaining just immense pressure.
keeping everything moving. And we assume it's invulnerable unless there is some massive, catastrophic trauma.
Like a heart attack or a physical injury.
Right. But what if I told you that a single, entirely mundane action, something as simple as like chewing your lunch or even just aggressively brushing your teeth in the morning, could inadvertently throw open the gates for this invading force? An invading force that's capable of bringing that vital engine to a complete and grinding halt.
It's terrifying. It is the absolute definition of a biological ambush.
Yeah.
And the terror of it really lies in the silence of that initial breach. You could just be going about your day totally unaware that your own circulatory system has been hijacked.
Hijacked to just transport an invading army directly to the most critical valve in your body.
Exactly.
So today, we are taking a documentary-style look into a really severe medical emergency. It's known as infective endocarditis, or IE.
Right.
And our mission on this deep dive is to trace the entire life cycle of this disease. We're going to explore how this microscopic ambush actually happens and the incredible biological bunker these invaders build right inside your heart.
The bunker concept is just fascinating.
It really is. And we're also going to look at the extreme lengths that doctors have to go to in order to catch it and stop it.
Right, because catching it is half the battle.
Absolutely. So we've pulled together a massive stack of medical literature for this. We're looking at comprehensive clinical pathogenesis notes on both pediatric and adult cases. We've got the highly specific 2023 modified Duke ISC-VID criteria.
Which is basically the global rulebook for diagnosing this.
Yeah, the ultimate diagnostic scorecard.
Yeah.
And we also have the American Heart Association guidelines for prevention.
And when you look at the raw data in these sources, I mean, one statistic immediately just jumps off the page.
Oh, the mortality rate.
Yeah. Despite all of our cutting-edge imaging technology and our most powerful intravenous antibiotics, infective endocarditis still maintains a chilling 20 to 25% mortality rate.
It's staggering. A quarter of the people who get this die.
Yeah. It is really a masterclass in the complex and often poorly understood interplay between our own bodies and the pathogens that live all around us.
That statistic alone really demands that we understand how this works. So let's start with the battlefield itself.
Okay.
When you're seeing infective endocarditis, the endo refers to the endocardium, right? Which is the smooth inner lining of the heart.
Correct.
And our sources note that while the bacteria or fungi can attack the mural endocardium, which are the flat inner walls of the heart chambers, or even septal defects, holes between the chambers,
Right.
the primary targets are always the cardiac valves. But they don't just attack these valves at random. There is a very distinct hierarchy of destruction here.
It's very predictable.
Yeah. The mitral valve is hit most frequently.
Yeah.
Then the aortic valve, sometimes both of them at the same time. The tricuspid valve is distant fourth, and then the pulmonic valve is almost never hit.
Right.
So why does the infection show such a strong preference for the mitral and aortic valves specifically?
Well, it really comes down to the sheer brutal physics of how blood moves.
Okay.
The human heart is divided into a right and a left side. The right side has a relatively easy job. It just receives depleted blood from the body and gently pushes it next door into the lungs.
So the pressure is low.
Exactly.
Yeah.
Very low pressure. But the left side of your heart, which is where the mitral and aortic valves live, that side has to forcefully eject oxygenated blood out to your entire body, your brain, your fingertips, your toes.
It's the heavy lifter of the cardiovascular system.
It is. And to do that, the left ventricle must generate immense pressure. And, well, with heavy lifting comes microscopic wear and tear. Because the left side operates under such a massive pressure gradient, those specific valves experience significantly more turbulence over a lifetime. I mean, imagine a river flowing smoothly versus a river rushing through a narrow, rocky gorge.
Oh, that's a good analogy.
Right. In the left side of the heart, the blood is rushing, it's swirling, and it's creating microscopic frictional damage against the delicate cellular lining of those valves. And the bacteria, they are essentially looking for those damaged, turbulent areas to lash onto.
And we actually see that borne out in the data regarding artificial valves, too.
We do?
Yeah, the sources specified that mechanical prosthetic valves and bioprosthetic valves, whether they're made of like carbon titanium or pig tissue, they exhibit equal rates of infection.
Which tells us something really important. The material itself doesn't grant you immunity. It's the turbulence created around the hardware that invites the infection.
Wow. Okay, so that brings us to the setup phase. Because before a single bacterium even arrives at the heart, something has to happen to make that valve welcoming to an invader.
Right. The ground has to be prepped.
The medical texts refer to this as the initiating lesion, specifically a non-bacterial thrombotic embolus, or NBTE.
EVTD.
And when I was reading this, I thought of it like a pothole forming on a busy highway long before a car actually hits it and causes a crash.
The pothole analogy captures the mechanism perfectly, actually, because a healthy heart valve is coated in these perfectly smooth endothelial cells. Blood just slides right off them.
Like Teflon.
Exactly like Teflon. But when you have that turbulent, high-pressure swirling we just discussed, it causes microtrauma. It physically strips away those smooth cells, exposing the raw collagen underneath.
Ouch.
Right. And your body senses this damage and immediately tries to patch it. It sends in platelets, those are the tiny cells responsible for clotting, and a protein called fibrin, and it weaves them together into a sticky mesh.
And this is the NBTE.
This is the NBTE. And notice the first word there, non-bacterial.
Right, so there's no infection yet. It's entirely sterile.
Exactly. It's just a clump of your own body's spackle trying to smooth over a rough patch. And, while we all experience microscopic wear and tear, some people have anatomical features that generate massive constant turbulence.
Like congenital issues.
Yes. Children born with structurally abnormal hearts are at an incredibly high risk. The texts specifically highlight conditions like ventricular septal defects or VSDs.
Okay, what happens mechanically with a VSD?
So if a child has a hole in the muscular wall separating the high-pressure left ventricle from the low-pressure right ventricle, blood violently shoots through that tiny gap every single time the heart beats.
Oh, wow.
Yeah. It creates a literal jet stream of turbulence that constantly strips the lining, and that leads to massive NBTE formation. We see the exact same physical phenomenon in patients with permanent valve scarring from rheumatic heart disease.
Okay, so the turbulence strips the lining,
Right.
the body lays down this sticky platelet pothole patch, and now the trap is set.
The trap is absolutely set.
The valve is basically covered in biological glue,
Mm-hmm.
and this is where the invaders enter the picture.
Right.
The texts introduce this concept of transient bacteremia, which means bacteria are just temporarily floating in the bloodstream.
Yes.
And when these circulating microbes wash over that sticky MBTE patch or over the artificial biofilm of like a pacemaker wire, they colonize it. And the primary culprits identified here are virulence-type streptococci and Staphylococcus aureus.
Those are the big two.
But what I found so fascinating is that these bacteria aren't just passively bumping into the clot and getting stuck like flies on flypaper.
Oh, no.
They actively participate in the adhesion.
They are heavily armed for the specific environment. Viridin streptococci, for instance, they possess these very specific surface proteins. The notes highlight something called the FEMA antigen.
FEMA.
Yeah. And you can think of FEMA as a molecular grappling hook. When the bacterium floats past the damaged valve, the FEMA antigen chemically binds directly to the fibrin and platelets in your body's pothole patch.
It locks on.
It locks on tight. And once they secure that beachhead, they begin to rapidly multiply.
Okay, but this raises a huge question. If these microbes require direct access to the bloodstream to reach the heart, how are they getting in?
Right, that's the scariest part.
Because this is where the epidemiological detective work gets incredibly unnerving. We know we are covered in bacteria. We are practically walking ecosystems. Our mouth, our GI tract, our bladder, they are just teeming with microbial life.
Millions of them.
And the statistics in our source material on how easily these microbes slip into our blood are staggering. It notes that dental extractions cause bacteremia in 40 to 100% of cases.
Which makes sense.
Yeah, having a tooth pulled is bloody, so that tracks. But it's the everyday actions that really caught me off guard.
Yeah.
Toothbrushing and flossing cause transient bacteremia in 20 to 68% of cases.
Let that sink in.
And simply chewing food introduces bacteria into the blood 7 to 51% of the time. Just chewing lunch.
It's wild because every time you chew a tough piece of bread or maybe you brush a little too hard, you cause these microscopic tears in your gingival tissue, your gums. Right. And the bacteria living in your mouth just slip through those micro tears directly into your capillaries. Now, for a healthy person with smooth, undamaged heart valves, This is a total non-issue.
Your body just handles it.
Exactly. Your white blood cells spot these transient invaders, and they clear them out of your bloodstream within minutes. But if you have that sticky NBTE patch waiting in your heart, those few minutes of circulation are all the bacteria need to deploy their grappling hooks and lock onto the valve.
Which completely upends how we think about dental prevention.
Yeah.
I feel like the conventional wisdom is always about, oh, I need to get an antibiotic prescription before I get a root canal.
Right. But the clinical reality demands a total paradigm shift here. If your gums are inflamed and they're bleeding slightly every single time you eat lunch or brush your teeth, you are subjecting your heart to low-grade bacteremia thousands of times a year.
Thousands of times.
Yeah. The cumulative risk of everyday poor oral hygiene is vastly more dangerous than any single isolated visit to the dentist. So the primary defense against infective endocarditis isn't a pill. It's maintaining pristine baseline oral health so your gums don't leak bacteria every time you take a bite of an apple.
That's a mind-blowing reframing of why we need to floss.
It really is.
But okay, let's pivot to what happens when that defense fails.
Okay.
A patient arrives at the hospital, they're incredibly sick, and the doctor is trying to figure out what exact bacterial species is destroying their heart.
Right.
Sometimes they draw blood and try to grow the bacteria in a lab, but nothing grows. It's called culture-negative endocarditis.
Which is a doctor's worst nightmare.
I can imagine. In those terrifying scenarios where the lab gives you nothing, the doctor basically has to become a profiler.
Exactly.
The clinical notes show that a patient's social and medical history often provides the only clues as to what family of pathogens to hunt down.
Because history taking in this context isn't just a formality, right? It is urgent microbiological targeting. If you know the entry point, you can often guess the invader.
Right. I'm looking at the risk factors mapped out in the text, and the sheer variety of entry points is wild. Let's deduce some of these together.
Okay.
If a doctor is reviewing a patient's history and sees a recent pregnancy, a gynecological procedure, or genitourinary disorder, the clinical profile shifts immediately to bugs like Enterococcus, Group B strep, or Neisseria gonorrhea. I assume that's simply because the mucosal lining of the genitourinary tract was the barrier that got breached.
Precisely. That is the exact mechanism, because the gastrointestinal and genitourinary tracts have a completely different resident flora than the mouth.
Right.
Enterococcus, for example, is this really tough, resilient bacterium that thrives in the gut and bowel. If a procedure disturbs that specific mucosal neighborhood, that is the flora that spills into the venous system.
Okay, now consider a patient with a history of injection drug use.
Yeah.
If someone is using a needle, they are bypassing the skin entirely.
Totally bypassing it.
They aren't relying on a micro tear in the gums. They're pushing environmental pathogens directly into a major vein. And the text points to a much more aggressive class of bugs here.
Oh, absolutely.
We're talking Staphylococcus aureus, Pseudomonas aeruginosa, and even fungi.
And we have to look at the anatomy of venous blood return to understand why this specific entry point is so dangerous.
Okay.
When you inject something into a vein in your arm, that blood travels directly to the right side of the heart first.
Right, because it has to go get oxygen from the lungs.
Exactly. So it hits the tricuspid valve before it ever reaches the lungs. This is why right-sided endocarditis is heavily associated with intravenous drug use, whereas in the general population, the right side is rarely affected.
Wow.
Furthermore, skin-dwelling bacteria like Staph aureus are just brutal. They don't just opportunistically colonize pre-existing damage like the viridans strep we talked about. Staph aureus is so aggressive, it can attach to and destroy completely normal, healthy heart valves.
It doesn't even need a pothole.
It brings its own shovel.
That's terrifying.
Yeah.
What about the connection to alcoholism and cirrhosis? The notes highlight pathogens like Bartonella, Aeromonas, or Listeria. How does liver disease invite a heart infection?
It comes down to filtration. The liver is the body's primary filtration system. Blood from your intestines, which is laden with trace amounts of bacteria that cross the gut wall every day, goes straight to the liver via the portal vein.
Okay.
And a healthy liver acts like a massive sieve. It's filled with these specialized immune cells called Kupffer cells that just devour these microbes.
Kupffer cells, right.
But in cirrhosis, the liver becomes hardened and scarred. The blood literally bypasses the filter, shunting directly into the general circulation. So suddenly, Unusual gut bacteria like Listeria or Aeromonas have free rein to circulate and find the heart.
So a doctor asking about your alcohol intake or past surgeries or even a recent burn injury isn't just taking down biographical trivia.
Not all.
They are trying to blindly aim their intravenous antibiotics while they wait for the lab to confirm the bacterial suspect.
Exactly. It's high-stakes profiling.
So let's go back to the heart itself. The bacteria have breached the perimeter, they found the turbulent pothole on the valve, and they've grappled on. What happens next?
Well, this is where they dig in.
Because the sources describe the clinical presentation as an escalating medical mystery, and it all revolves around this concept of the vegetation.
Yes, the vegetation. Once the bacteria are anchored, they don't just sit there exposed to the rushing blood. They actually begin to manipulate the environment.
How so?
They trigger the body's coagulation cascade all over again. The process of platelet aggregation and fibrin deposition, that exact same spackle that created the initial pothole, it accelerates wildly right around the bacteria.
Wow.
The microbes essentially wrap themselves in the patient's own clotting
They're
factors.
building a bunker, and they are using our own biology as the concrete.
That is exactly what they're doing. And what's insidious here isn't just the physical barrier.
Yeah.
By wrapping themselves in the host platelets and fibrin, the bacteria become virtually invisible to our immune system.
Because it's our own tissue.
Right. Our neutrophils, our white blood cell soldiers, they just circulate right past the vegetation because the outside of it looks entirely like normal human tissue.
But burying yourself under thick layers of biological concrete creates a unique problem for the bacteria as well, doesn't it?
It does.
Because if they're cut off from the immune system, they're also cut off from the blood supply. The organisms trapped deep inside the core of this growing vegetation are starved of nutrients and oxygen.
And to survive that starvation, the bacteria profoundly alter their metabolism. They enter a state of deep dormancy, a hibernation phase. They
Right.
completely stop multiplying and they stop building their cellular structures.
And this hibernation phase is the crux of why infective endocarditis is so incredibly difficult to cure.
Absolutely.
Because if you're wondering why we can't just give the patient a standard 5-day course of penicillin and be done with it, this is exactly why.
Right, because it requires a dive into how our best antibiotics actually function. You know, many of our most powerful bactericidal drugs, like the beta-lactam penicillins or vancomycin, they're designed to interfere with bacterial cell wall synthesis.
Okay, so they attack the construction process.
Exactly. They wait for a bacterium to try and build a new wall to divide, and then they sabotage the construction, causing the bacterium to rupture and die.
But if the bacteria are hibernating deep inside the vegetation, they aren't building anything.
Exactly the problem. They become highly refractory to the drugs. The antibiotics just wash over the dormant bacteria, but because there is no active construction to sabotage, the drugs essentially bounce right off.
Wow.
The bacteria achieve profound antibiotic resistance not through genetic mutation, but simply by going to sleep.
That is brilliantly evil. Meanwhile, as this hardened, shielded bunker of bacteria grows larger and larger on the valve, how does the patient at home actually feel?
Well, it varies wildly.
Yeah, our sources map out a spectrum of symptoms that varies based entirely on which organism is building the bunker. Right. If the culprit is viridans-type streptococci, the text describes symptoms that are terrifyingly mild and nonspecific. We are talking about a prolonged low-grade fever with afternoon elevations, unexplained fatigue, weight loss, myalgia, which is muscle pain, and arthralgia, joint aches.
It is the textbook definition of a slow burn. In medicine, this is known as subacute infective endocarditis.
And if you're sitting at home experiencing a low-grade fever and you feel achy and exhausted for a month, your first thought is that you have, like, long COVID, or maybe a stubborn flu, or you're just burned out from work.
You are absolutely not thinking there's a hardened bunker of bacteria slowly eating away at the internal architecture of your heart.
Right. Patients must ignore these symptoms for months.
They do, routinely. They take some ibuprofen, the fever dips, and they go to work. And by the time the exhaustion finally forces them into a clinic, the valve might already be structurally compromised.
That's terrifying.
It is. But contrast that with an infection driven by Staphylococcus aureus. There is no mystery there, and there is no ignoring it. It strikes with acute, terrifying severity.
High, spiking, intermittent fever.
Yes, rigors, which are these violent shaking chills, sudden prostration, meaning the patient is so physically weakened they cannot even stand up.
So Staph aureus doesn't smolder, it detonates.
It absolutely detonates. Acute infective endocarditis.
Okay, so whether it's the months-long slow burn or the sudden acute strike, The patient eventually ends up sitting on an examination table. The doctor takes out their stethoscope. What are the classic physical signs they are hunting for?
The loudest alarm bell is a new or changing heart murmur.
Okay.
As that bacterial bunker grows, it physically obstructs the valve opening, or the bacteria literally eat away the valve leaflets, causing them to leak. So the smooth, rhythmic sound of blood flowing becomes harsh and turbulent.
Right. The sound of the river changes.
Exactly. If a patient presents with a fever of unknown origin and the physician hears a heart murmur that was not documented in their physical exam 6 months ago,
Red flag.
massive red flag. Infective endocarditis jumps straight to the top of the differential diagnosis list. The sources also mention splenomegaly, which is an enlarged spleen in about half of all cases.
Which makes sense mechanically, right? The spleen acts as the body's primary blood filter, and it's just working overdrive trying to clear the massive amounts of immune debris generated by this chronic war.
Exactly. It swells up from the workload.
But we have to talk about the famous dermatological clues, the physical skin signs that are basically burned into the brain of every medical student.
Oh, yes. The classic signs.
The notes detail Janeway lesions, Osler's nodes, and Roth spots. And the source text draws a fascinating, very firm line between what causes these different signs.
Yeah.
Let's unpack the biology here, starting with Janeway lesions. What are they?
Janeway lesions are small, completely painless, flat red spots that typically appear on the palms of the hands or the soles of the feet. And these are driven by a purely vascular phenomena.
Vascular. Okay, how?
Imagine the bunker on the heart valve. It is constantly being battered by the rushing current of blood, and tiny microscopic pieces of that infected bunker occasionally break off.
Oh, gross.
These are called septic emboli, and they travel through the arterial system until the blood vessels get too narrow to pass, usually in the tiny capillaries of the hands and feet. They get stuck, and they cause a tiny, localized microhemorrhage.
It's a physical chunk of bacteria plugged in a pipe.
Exactly. And because they don't typically lodge near major nerve endings in a way that causes acute swelling, they are totally painless.
So it's basically a painless micromissile.
Right.
But Osler's nodes are entirely different.
Osler's nodes are the exact opposite. They're very painful, raised, purplish nodules, and they're almost exclusively found on the fleshy pads of the fingers and toes.
Ouch.
Yeah, and these are not caused by physical chunks of the bunker breaking off. These, along with Roth spots, which are flame-shaped hemorrhages seen in the retina of the eye, are an immunologic phenomenon.
Let's break down how an immune reaction causes painful purple lumps on your fingers.
So, as your body wages this month-long war against the heart infection, your immune system just churns out massive quantities of antibodies.
Right?
These antibodies circulate in the blood and they bind to the bacterial antigens, the cellular debris shed by the infection. And when antibodies bind to antigens in the blood, they form what are called immune complexes.
Okay, I picture these immune complexes like microscopic biological tumbleweeds just rolling through the bloodstream.
That's a great way to visualize it. These sticky biological tumbleweeds circulate until they get wedged in the microscopic blood vessels of your fingertips or your retinas.
And then what?
Your body spots this traffic jam and reacts aggressively. It sends in inflammatory cells like a biological SWAT team, and this triggers massive localized swelling. Because the fleshy pads of your fingers are packed with sensitive nerve endings, the acute swelling from that immune response compresses those nerves.
Oh, wow.
That is exactly why Osler's nodes are exquisitely tender to the touch.
Fascinating. And the clinical notes also highlight clubbing of the fingers, which is a bulbous deformity of the fingertips.
Yes.
And splinter hemorrhages, which look exactly like tiny dark wood splinters trapped under the fingernails.
Yes.
All is further evidence of this widespread vascular and immunologic chaos.
It's a full system meltdown.
So the body is shedding microscopic emboli and immune tumbleweeds. But the complications take a catastrophic turn when the bunker doesn't just shed cells, but structurally fails.
Right.
The text notes that the vegetation is friable, meaning it's highly fragile. And the heart is slamming against this fragile mass roughly 100,000 times a day.
Mm-hmm.
What happens when a significant chunk of the vegetation actually breaks loose?
It becomes a macroembolus, a large infected missile traveling at high velocity through the circulatory system. And the clinical fallout depends entirely on the geography of the heart. Which side did the missile launch from?
Right, because the plumbing goes to different places.
Exactly.
The text highlights that if the endocarditis is right-sided, which, as we discussed, is common in kids with uncorrected ventricular septal defects or adults with a history of 5E drug use, the anatomy dictates the outcome. The right ventricle pumps blood directly to the lungs.
Right.
So the right heart fires that infected embolus straight into the pulmonary artery. It lodges in the lung tissue, creating septic pulmonary emboli. The patient starts coughing up blood, experiencing severe chest pain as the infected clot literally rots a hole in their lung.
It's devastating. But if the vegetation is on the left side, the mitral or aortic valves, the scenario is arguably even worse.
Really? Worse than rotting your lung?
Yes, because the left heart pumps blood out into the entire systemic circulation. That infected missile could go anywhere in the body. If it shoots up the carotid artery, it lodges in the brain, causing a massive embolic stroke or seeding a cerebral abscess.
Oh, God. The sources mention it can also lodge in the wall of an artery and weaken it, creating what's called a mycotic aneurysm.
Yes, mycotic aneurysms are ticking time bombs.
To understand that, I like to imagine a garden hose with a weak spot in the rubber. The water pressure causes that weak spot to balloon outward.
Exactly.
And that ballooning is highly prone to sudden fatal rupture. If that happens in the brain or the abdomen, the patient can bleed out internally in minutes.
And the list of embolic complications is grim. Meningitis, if the bug is pneumococcus. Renal abscesses, where the kidneys fill with pus.
But the complication that struck me as the absolute most mechanically terrifying is what the infection does to the heart itself when it spreads beyond the valve into the cardiac muscle.
Right, forming an intraseptal myocardial abscess.
Yes. What is happening there?
This is a lethal escalation. The heart isn't just a muscle, it has a highly specialized internal electrical grid.
Okay.
The sinoatrial node at the top of the heart generates an electrical spark, and that spark travels down a biological wire called the AV node and the bundle of His2 to tell the bottom chambers exactly when to contract.
So it keeps the rhythm.
Yes. And this electrical wiring runs directly through the muscular septum that divides the chambers. If the bacterial infection burrows into that septum and forms an abscess, it literally eats through the electrical wiring.
The signal gets cut.
The clinical term is complete heart block. The top of the heart is firing, but the signal cannot reach the bottom chambers. The ventricles stop contracting in rhythm, the pump stops coordinating, and without immediate intervention, usually inserting a temporary pacemaker, the patient's circulation just collapses.
That is absolutely horrifying. So to stop the disease from reaching that catastrophic breaking point, doctors must investigate and confirm the diagnosis as rapidly as possible.
It's a race against time.
This brings us to part 4, the investigation, radiology, labs, and the Duke criteria. How do you catch a stealthy, hibernating bunker? The golden rule, according to the clinical notes, begins with the blood cultures.
Blood cultures are everything.
The doctor needs to prove the bug is in the blood. And the text is very strict about the protocol here. Up to 5 separate blood samples may be required. And the volume drawn is critical. 4 milliliters for an infant, but 10 to 15 milliliters for an adolescent or adult. Why such high volume?
That high volume is necessary because the concentration of bacteria in the bloodstream might be shockingly low.
Right, because they're mostly in the bunker.
Exactly. Remember, the vast majority of the bacteria are hiding inside the vegetation on the heart valve. Only a tiny, tiny fraction are shedding into the general circulation at any given moment. So if you only draw 1 milliliter of blood, you might simply miss the few bacteria swimming past.
But there is a detail in the source material regarding these blood cultures that is completely counterintuitive to me.
What's that?
Normally, if someone has an infection, you want to draw their blood when they spike a high fever, right?
Yep.
Because that's when the bacteria are surging. But the notes say the timing of the draw is actually not as important as meticulous skin preparation before you insert the needle.
Yeah.
Why does the skin prep matter more than the fever spike?
It speaks to the unique physiology of this specific disease. In infective endocarditis, the bacteremia is continuous.
Oh.
It's just a steady, microscopic trickle of bacteria shedding from the valve 24/7. So you don't need to wait for a fever spike. The bacteria are always there.
I see.
However, because the bacterial count in the blood is so incredibly low, your blood sample is very vulnerable to contamination. If the nurse does not scrub the patient's arm with antiseptics meticulously, the needle will push the normal, healthy Staphylococcus epidermidis that lives harmlessly on the patient's skin into the blood sample vial.
And when the lab puts that vial in the incubator,
That skin bacteria will grow.
and the doctor will look at the lab report, see a staph infection, and assume that's what's eating the heart valve.
Exactly. They will prescribe heavy antibiotics targeting the wrong bug, completely missing the actual pathogen causing the endocarditis. A sloppy skin prep can derail the entire treatment plan.
That is wild.
But the data shows that if you execute the prep correctly, The first two cultures recover the causative agent 90% of the time.
The lab also has to be patient, right?
Very patient. For those hibernating, slow-growing bugs, the text notes that prolonged culture on enriched media, which is basically giving the bacteria a highly nutritious chemical soup, might be needed to coax them into growing so they can actually be identified.
And doctors will also run a full blood count, ESR, and CRP, which are generalized inflammatory markers that confirm the body is actively fighting a severe threat.
Right, it gives you the overall inflammatory picture.
So while the laboratory technicians are trying to coax the bug to grow in a petri dish, the radiology department is trying to take a physical picture of the bunker inside the heart.
Which is not easy.
No, the primary tool deployed is 2D echocardiography, which is essentially a high-resolution ultrasound of the beating heart. What does that show them?
The echocardiogram is really the workhorse of cardiac imaging. It allows the cardiologist to actually visualize the vegetation clinging to the valve leaflet. It assesses the mechanical damage, like how badly the valve is regurgitating or leaking blood backwards.
Right.
And crucially, the echo allows the doctor to measure the exact size of the bunker. This is predictive.
Predictive is emboli.
Yes. The source material explicitly states that vegetations larger than 1 centimeter are considered a major risk for embolization. If the mass is larger than a centimeter, the likelihood of a chunk breaking off and causing a stroke skyrockets.
But ultrasound has its limits, especially when a patient already has artificial hardware in their heart. High-frequency sound waves cannot penetrate dense metal or plastic.
They cannot.
If a patient has a mechanical titanium valve, it casts an acoustic shadow. The infection could be raging on the back side of that valve, and the echo simply wouldn't see it.
Exactly. And that is where advanced imaging comes into play. The notes mention cardiac CT scans, which are used to find definite paravalvular lesions,
Which means
meaning the infection has eaten outside the boundaries of the valve and burrowed into the surrounding heart tissue.
okay, and then there is the PET scan. Positron emission computed tomography using 18F-FDG. This sounds like science fiction to me. What exactly is a PT scan looking for?
It is a brilliant, brilliant application of cellular metabolism. 18F-FDG is a radioactive glucose analog.
Glowing sugar.
Essentially, yes, glowing sugar. The PET scan isn't looking at the physical shape of the heart the way an ultrasound or a CT does. It maps metabolic demand.
Oh.
Think about it. Bacteria that are rapidly dividing and the massive swarms of white blood cells trying to kill them, they require a huge amount of energy.
So they eat a lot of sugar.
Exactly. They consume sugar at a voracious rate compared to normal resting heart tissue.
Yeah.
So the patient is injected with the radioactive sugar and the scanner watches where it goes.
Wow.
Right. If a patient has a mechanical prosthetic valve casting an acoustic shadow, but the PET scan shows a blazing ring of radioactive sugar consumption right around that hardware, you have your answer.
It proves there is an active high-energy war zone there, even if you can't see the physical bunker on an ultrasound.
Exactly.
Incredible. So the physician has gathered the evidence. They have the blood cultures from the lab, they have the ultrasound or the PT scan, and they have the clinical history. Now, they must render a diagnosis.
Right.
And they do this using the 2023 modified Duke ISC VID criteria. I read through this document, and it functions less like a clinical suggestion and more like a rigorous legal scorecard.
It is very strict.
You cannot just guess that a patient has IE. You have to prove it mathematically against the scorecard.
Standardization is vital when the treatment involves highly toxic drugs and open-heart surgery. You are trying to reach the definitive verdict of definite IE.
So how does a doctor score a definite IE? The criteria lay out two distinct paths. Option 1 is pathologic criteria. This is the smoking gun. It requires the direct identification of the microorganism from a surgical specimen or an embolus. Basically, the surgeons had to open the patient's chest, cut out the vegetation, or vascular surgeons pulled a clot out of the patient's leg, put it under a microscope, and proved it was infected.
But obviously the goal of modern medicine is to diagnose the patient long, long before you were forced to crack their sternum open.
Which brings us to option 2, the clinical criteria.
This is where the scorecard logic kicks in.
Right. To achieve a clinical diagnosis of definite IE, the doctor must check off specific combinations of clues, either 2 major criteria or 1 major and 3 minor criteria, or 5 minor criteria. It's a fascinating weighting system. Let's break down what elevates a clue to major status versus minor status.
Sure. The major criteria represent the heaviest, most undeniable evidence. The first major criterion is typical positive blood cultures. meaning the lab isolated a bacterium from your blood that is universally recognized as a classic endocarditis pathogen, like viridin streptococci or Staph aureus. And it has to be drawn from multiple separate blood samples to rule out contamination.
Right. And the second?
The second major criterion is positive imaging. Finding the physical vegetation, finding an intracardiac abscess, or spotting a new valve leak on an echocardiogram or a CT, or, as we mentioned, visualizing that blazing ring of abnormal metabolism on a PET scan.
Finding the specific bug and visually confirming the bunker. Those are the majors.
Exactly.
In the minor criteria.
The minor criteria are the supporting circumstantial evidence we discussed earlier, like a predisposing structural heart condition or a history of injection drug use, a sustained fever over 78 degrees Celsius, which is 100.4 degrees Fahrenheit,
Okay.
and then those signs. The vascular phenomena, like the painless Janeway lesions on the palms or arterial emboli. The immunologic phenomena, like the painful Osler's nodes, Roth spots, or a positive rheumatoid factor indicating immune complexes in the blood.
And lab results that don't quite hit the major threshold.
Exactly. Microbiological evidence that is suspicious but doesn't quite meet the strict major threshold, like maybe a single positive blood culture for an unusual environmental bug.
Okay, so the doctor tallies the scorecard. 1 major culture, 3 minor physical signs.
Yeah.
The diagnosis is locked in. Definite infective endocarditis. The mystery is solved, but the hardest part is actually just beginning.
Yes, the treatment is brutal.
We move to part 5, the treatment plan. This phase of the clinical notes reads like a blueprint for a grueling war of attrition. Medical warfare running in parallel with the constant looming threat of open-heart surgery.
And the clock is ticking. Treatment must begin immediately. Often the patient is so unstable that the physician cannot wait the 48 hours for the lab to identify the specific bug in the blood cultures.
They just have to go.
They must initiate empirical therapy, which is an intensely educated, high-powered guess based on the patient's profile.
And the sources outline the exact strategy for this empirical therapy. If a patient has an infection on their native, natural heart valves, and their clinical history suggests a high risk of aggressive bugs like Staph aureus and Pterococcus or viridin streptococci, the initial heavy artillery deployed is a combination of 2 powerful intravenous antibiotics, vancomycin and gentamicin.
Right, and those 2 specific drugs are chosen for their profound synergy.
They work together.
They work together mechanically. Vancomycin acts as a battering ram against the bacterial cell wall, compromising its structural integrity. Once the wall is breached, gentamicin rushes inside the bacterial cell and binds to the ribosomes, completely shutting down the bacteria's ability to manufacture proteins.
It is a devastating 1-2 punch.
It really is.
But as we discussed with the hibernation bunker, dropping a chemical bomb for a few days isn't enough to clear the infection, because the bacteria deep inside the vegetation are asleep.
Right.
The text mandates a timeline that sounds psychologically and physically grueling. Intravenous therapy must continue for 4 to 6 uninterrupted weeks.
The length of the treatment is completely dictated by the slow metabolic rate of the hibernating bacteria. The primary goal is to avoid recrudescence.
Which means the infection comes back.
Exactly, the catastrophic return of the infection the moment the drugs are withdrawn. You have to maintain high toxic serum bactericidal levels in the patient's blood for a month and a half.
Wow.
The strategy is to constantly batter the outside of that bunker, just waiting out the dormant bacteria. As the outer layers of the vegetation slowly dissolve and the core bacteria finally wake up and try to multiply, the vancomycin is there waiting to shatter their newly forming cell wall.
It's a 6-week chemical siege designed to literally starve and break the invaders.
That's the perfect way to describe it, a siege.
But while the antibiotics are laying siege to the bacteria, the medical team is fighting a second war at the exact same time, managing the mechanical fallout. The patient's heart valve is often severely damaged and leaking fluid backwards. The pump is failing, so doctors must treat concurrent heart failure. They administer diuretics, essentially forcing the kidneys to excrete water, pulling excess fluid out of the patient's drowning lungs.
It's a delicate balance.
They use digoxin to alter the calcium levels in the heart muscle, helping it pump with more force. And they administer afterload-reducing agents, medications, that dilate the blood vessels, reducing the resistance the damaged heart has to pump against.
And if those septic emboli we talked about earlier have lodged in the kidneys and caused renal failure,
Right.
the patient might require a machine to do the work of their kidneys through hemodialysis.
But despite the brilliance of vancomycin synergy and diuretics, the chemical siege sometimes fails. the bacteria are too entrenched or the structural damage is just too severe, that is when the medical team hits the red lines, the surgical indications.
This is the moment the cardiologist looks at the surgeon and says, "We can't wait for the antibiotics to work. We have to go in mechanically."
And the clinical notes provide absolute triggers for when the chest must be cracked open. I want to look at these closely because they really highlight the raw physical destruction of the disease.
Let's do it. The first and really most common trigger is severe aortic or mitral valve involvement resulting in intractable heart failure.
Intractable meaning medications aren't working.
Exactly. The infection has literally eaten away the leaflets of the valve. The blood is sloshing freely backwards, the pump is mechanically destroyed, and no amount of diuretics will fix it. The surgeon must go in, cut out the rotting tissue, and sew in an artificial valve just to restore forward blood flow.
The second trigger involved those vascular time bombs we talked about, mycotic aneurysms or rupture of an aortic sinus. The structural integrity of the main plumbing leading out of the heart is blowing out. If it ruptures, the patient dies instantly.
Yeah, a surgeon has to clamp the aorta and graft in a synthetic tube immediately.
The third trigger is what we discussed earlier regarding the electrical grid. Interseptal abscesses causing complete heart block. The infection has melted the wiring.
Right. The surgeon must physically excise the pocket of pus from the heart muscle and almost certainly install a permanent pacemaker to artificially regulate the heartbeat.
There is another unique trigger mentioned, dehiscence of an intracardiac patch. What does that mean?
So if a child had a hole in their heart repaired years ago with a synthetic patch, the bacteria absolutely love to colonize the edges of that material.
Ah.
If the infection causes the stitches to rot and the patch begins literally tearing away from the heart wall, that's dehiscence, it must be surgically secured.
Okay. Beyond the structural failures, there are also triggers based purely on the failure of the antibiotic siege.
Yes.
If blood cultures remain positive after 7 to 10 days of appropriate intravenous antibiotics, meaning the drugs are doing nothing to stop the bacteria from swarming into the blood, you have to physically remove the source.
You have no choice.
If the echocardiogram shows the vegetation is actually growing larger despite 6 weeks of vancomycin, or, tragically, if the patient continues to throw recurrent emboli, suffering stroke after stroke while sitting in the hospital bed.
You cannot wait for the siege to end. You have to mechanically extract the bunker.
Now, the clinical notes detail one final scenario that pushes medical science to its absolute limits. The fungal nightmare.
Fungal endocarditis.
We focus mostly on bacteria, but fungal infective endocarditis exists, and it is a distinctly different beast.
Very different.
The text notes this is often seen in highly vulnerable populations. Patients recovering from recent open-heart surgery, severely immunosuppressed individuals, or patients who have been on massive, prolonged courses of broad-spectrum antibiotics that wiped out all their normal bacterial flora, creating a biological vacuum that aggressive fungi exploit.
And the prognosis for fungal endocarditis is dismal. It is so hard to treat.
Why is that?
Because fungi are eukaryotic organisms, meaning their cellular structure is much closer to human cells than bacteria are.
Oh, so if you try to kill them.
Exactly. It makes them incredibly difficult to kill without also inflicting massive toxic damage on the patient's own organs. Furthermore, the vegetations, the bunkers built by fungi, particularly Candida or Aspergillus, are massive, dense, and incredibly crumbly.
Friable.
Very friable, making them extremely prone to showering the brain with huge emboli.
The treatment protocol reflects that desperation. It requires heavy-duty antifungal agents like amphotericin B, which I've heard is often referred to in hospitals as amphoterrible because of its severe side effects.
Yeah, amphoterrible. It's a brutal drug.
And they use it alongside a drug called 5-fluorocytosine. But the text bluntly admits that medical therapy alone is rarely curative. Surgery to physically excise the massive fungal clump is almost always attempted, but even with surgery, survival rates are heartbreakingly low.
The source material does mention one last-ditch, deeply experimental effort for exceptionally high-risk patients who are just too unstable to survive an open-heart operation.
What's that?
Doctors may attempt to use recombinant tissue plasminogen activation, or TPA.
Let's explain the mechanics of TPA, because I know it's a famous drug in stroke protocols.
Right. It is a profound clot-busting agent. In a normal stroke, a blood clot blocks an artery in the brain. You inject TPA, it circulates in the blood, and when it finds the clot, it activates a protein called plasmin that acts like molecular scissors.
Scissors?
Yeah, literally cutting the fibrin mesh of the clot apart, melting it. So the experimental idea in endocarditis is to inject TPA to chemically finalize the massive fibrin matrix of the intracardiac vegetation.
You are trying to melt the bunker chemically without opening the chest.
Exactly, but it is an act of sheer desperation. Melting the bunker also means risking the release of a massive shower of infectious debris straight into the brain or lungs.
That is a terrifying gamble. And that harsh reality brings us to the final segment of our deep dive: prevention, prognosis, and looking ahead.
Okay.
Let's start with the hard numbers. We have traced this disease from a micro tear in the gums to a radioactive PET scan through 6 weeks of IV antibiotics and open chest surgery. And despite all of that incredible medical intervention, the mortality rate holds at 20 to 25%.
And survival is rarely a return to baseline.
That's right.
Serious morbidity plagues 50 to 60% of pediatric survivors. The most common, devastating long-term consequence is chronic heart failure.
Because the valve is ruined.
Yes. The infection might be dead, but the aortic or mitral valve is permanently scarred, thickened, and leaking. The child faces a lifetime of restricted physical activity, daily medications, and the high likelihood of needing multiple valve replacement surgeries as they grow.
Because the stakes of catching this disease are so extraordinarily high, prevention is paramount. The American Heart Association has established very specific guidelines for who should receive preemptive antibiotics, known as prophylaxis, before undergoing procedures that might introduce bacteria into the blood.
Right.
And what fascinated me reading the historical context is how drastically they have narrowed this list down over the years.
It is a major, major shift in public health policy. 2 decades ago, if you had a faint heart murmur, your dentist gave you antibiotics before cleaning.
Just standard procedure.
Right. The medical community was terrified of endocarditis. But extensive research revealed 2 critical facts. First, as we discussed earlier, the cumulative bacteremia from daily toothbrushing is vastly greater than the bacteremia from a single dental visit.
Thousands of times greater.
Exactly. And second, handing out millions of doses of antibiotics for every single dental cleaning was accelerating global antibiotic resistance. We were breeding superbugs.
So the risk of creating untreatable superbugs outweighed the protective benefit for the average person.
Precisely. So the AHA drastically restricted the guidelines. Today, prophylaxis is reserved strictly for the absolute highest risk individuals, patients where an infection would almost certainly be fatal.
Let's clearly define that high-risk list.
Okay.
It includes, first, individuals with prosthetic heart valves, or prosthetic materials used for surgical valve repairs. Their hearts contain foreign hardware, which is a magnet for biofilm. Second, anyone with a previous history of infective endocarditis. Their heart architecture is already scarred and proven vulnerable. Third, cardiac transplant recipients who develop valvulopathy, meaning a structural problem with a valve inside their new donor heart. And fourth, specific categories of congenital heart diseases.
And they are very, very specific about which congenital defects qualify.
Right.
Unrepaired cyanotic heart disease, meaning babies born with defects so severe their blood doesn't oxygenate properly, leaving them with a blue tint. This includes children with palliative shunts. It also includes completely repaired congenital defects, but only during the first 6 months after the surgery if prosthetic material was used.
Why only 6 months? That seems arbitrary.
It's actually biological. It takes roughly 6 months for the patient's own body to grow a fresh, smooth layer of natural endothelial cells over the synthetic patch. Yeah. Once that natural biological sealant covers the hardware, the risk of bacterial adhesion plummets.
That's amazing.
It is. However, if there are residual defects right next to the patch that prevent that smooth lining from growing perfectly, the patient requires lifelong prophylaxis. The AHA text also notes a minor caveat that patients with permanently damaged valves from rheumatic heart disease may also be considered for prophylaxis in certain regions, depending on the severity.
So if you fall into one of those critical high-risk categories, when exactly do you need the chemical shield? The guidelines draw a very clear line based on the depth of the procedure.
Right.
Prophylaxis is mandated for all dental procedures that involve manipulation of gingival tissue, the periapical region of the teeth deep in the roots, or any perforation of the oral mucosa.
Essentially, if the dentist's tools are going deep into the gum pockets where the most aggressive anaerobic bacteria live, you absolutely need protection. But the AHA explicitly carves out exceptions to avoid unnecessary drug use. You do not need antibiotics for the natural shedding of baby teeth. You don't need them for routine orthodontic bracket adjustments. You don't need them if you accidentally bite your lip and it bleeds.
And crucially, the guidelines state that genitourinary and gastrointestinal procedures, like colonoscopies or urinary tract surgeries, are no longer recommended for routine endocarditis prophylaxis.
Which is a big change from the past.
Yeah. The clinical evidence just did not support the idea that the protective benefit outweighed the dangers of antibiotic overuse in those specific scenarios.
Exactly. The focus is almost entirely on the massive bacterial loads in the mouth.
Right.
When a high-risk patient does go in for deep dental work, the pharmacological arsenal is highly standardized. The goal is to maximize the concentration of the antibiotic in the bloodstream precisely at the moment the dentist's drill breaks the tissue.
So for adults, the standard shield is amoxicillin, taken orally 1 hour before the procedure. And the dosage is aggressive, a full 2 grams, designed to spike blood levels high enough to instantly slaughter transient bacteria.
Right.
For children, the dose is calibrated by weight at 50 milligrams per kilogram. If a patient is unable to take oral medication, the team pivots to ampicillin administered intramuscularly or intravenously, or drugs like cefazolin.
And if they're allergic to penicillin?
The guidelines provide alternatives like cephalexin, clindamycin, or macrolides like azithromycin, ensuring that every patient has a chemical option to guard the gates during those vulnerable hours.
It is a highly protocolized, meticulously timed defense against an invisible enemy.
And that profound reality really wraps up our journey today. We have traced an incredibly intense narrative. We started by exploring the sheer physics of blood flow, watching how a single turbulent swirl against a scarred mitral valve strips away the lining. We watched the body try to heal itself by building a sterile pothole of platelets, only to be ambushed by everyday bacteria that snuck into the bloodstream during a mundane lunch. We unpacked the terrifying ingenuity of how those bacteria use protein grappling hooks to build an impenetrable biological bunker, starving themselves into deep hibernation to shrug off our strongest drugs.
We walked through the grueling investigative puzzle of catching the disease, too. Drawing precise volumes of blood to avoid skin contamination, deploying radioactive sugars to light up hidden infections on a PET scan, and tallying the rigorous points of the Duke criteria.
Right, and we confronted the brutal reality of a 6-week chemical siege using synergistic antibiotics and the terrifying red lines that force a surgeon to urgently crack open a chest to remove a rotting valve.
It is a narrative that constantly reminds us of the profound fragility and the fierce interwoven complexity of the human body.
Thank you for joining us on this intense medical deep dive.
But before we go, I want to leave you with a final, lingering thought to mull over, building on the realities we've uncovered today. We live in an era of miraculous medical advancement. We are surviving cardiac conditions that were universally fatal just a generation ago. But to achieve that survival, we are putting more artificial materials into the human body than at any point in history.
That's true.
Our hearts are increasingly augmented with titanium prosthetic valves, complex synthetic pacemakers, intracardiac patches, and synthetic vascular grafts. We know that these foreign materials create turbulence. And we know that bacterial biofilms view these artificial surfaces as the ultimate impenetrable biological bunkers.
Right.
So as we continue to implant more and more hardware into an aging population, are we inadvertently engineering a new, perfect landscape for infective endocarditis to thrive in the 21st century? How will the biomaterials and synthetic tissues of the future need to evolve to actively repel these invaders in a war we clearly cannot always win with antibiotics alone?
That is a brilliant, slightly chilling question that strikes at the very future of surgical medicine. Until next time, remember that relentless microscopic battleground beating inside your chest. Stay curious, stay informed, and we'll see you on the next deep dive.